Today we will be delving into a critical topic of Googlies of Pyrexia in pregnancy. Our distinguished speaker today, orator Dr. Pankaj Desai, who has been president of Oxy in 2007.
This lecture will not end here. These are my contacting addresses. You can contact me at any of these points, and I honestly tell you, I will reply. So it is my commitment, my dharma, my duty. And therefore, today I decided not to touch a boring subject. Routines are boring. Routines are surely boring like this picture. And so my aim is to wake you up today. I am going to throw Googlies. Googlies has nothing to do with Google. I am reminding you of this gentleman here. He was a master of Googlies. It is a magic they do with the ball. I am sure Dr. Pardesi will be knowing, and those of you who are interested in cricket know about Shane Warne, about Bhagwat Chandrasekhar, more so Bishan Bedi. The way they catch the ball and turn it, that is what clinical practice does to us so many times. And a googly comes up where you don't expect in something in fever, and that googly comes. If you want to be connected, actually this can also become a discussion if it is a physical lecture. So you can pull out a piece of paper, do a brain activity. Pull out a piece of paper. I have an electronic paper here. You can pull out, write your diagnosis when the situation is developing, and see whether it is correct or not, whether it matches. And then let us see how you will solve the googling. The first situation is quite scary for any generalist. We are 90% of us are generalists. In a typical day, we give antenatal care, we suture episiotomy, we do 11 to 14 week scan, we remove such a big uterus on endoscopic on a TLH. This is our routine day. We are generalists. We are not general practitioners, but we are not super specialists. And this situation is scary to even a very experienced obstetrician like me or Dr. Pardesi or Dr. Anju. See this. A 26 years old preemie, 31 weeks pregnant, presented to the hospital with complaints of epigastric pain, gum bleeding, and petechial hemorrhage for 1 day. She had a high-grade fever for 5 days just prior to admission. She was first seen at antenatal clinic, the same clinic 12 weeks. At 12 weeks, there was no abnormality detected until this presentation. She had no challenges. Her past medical and family history were non-contributory. On admission, her body temperature was 37, just 37. Blood pressure normal, pulse rate was 80, respiratory rate was 20 per minute. Probably she had taken a paracetamol. On general clinical examination is going to be very important in this entire session, because you are going to be misled by investigations. And therefore it becomes a googling. She had a mild dehydration, normal breath sounds and heart sounds. I hope how many of you are auscultating, please do. Her liver was enlarged 1 centimeter below the right costal margin with mild tenderness. The fundal height was compatible with 32 weeks gestation, and fetal heart rate was 144 to 148 beats per minute. Petechi, on the side of 1 to 2 millimeter diameter, were found around her face, forearms, and both thighs. Many diagnoses can come. You can scribble some of them. Some of them season is just got over. You can just scribble your diagnosis, then compare with me. You will surely like to know about the laboratory picture now that you have done a thorough clinical examination. Let us see the laboratory report. Hemoglobin 11.9, hematocrit 35%, WBC count 7440, rest being normal, but this was buggy. Platelet count was only 10,100. Now this is going to bug every one of you. Only on basis of platelet count, the clinician diagnosed her as dengue fever. Treated with intravenous fluid replacement, she was put under close observation for vital signs and bleeding diathesis. You know, once you diagnose dengue, it is more symptomatic and you have to wait. They waited for 24 hours later. The epigastric pain disappeared. The vital signs were within normal limits. The hematocrit was 30% and the platelet count was 6320. It fell. Even the hematocrit fell. That makes it scary. You still, let us see what happens on progress. The progression of the condition was observed. She was still in the hospital. Platelet concentration was prepared, was kept ready, but not used because the patient had no clinical bleeding. This is a message. There are so many messages which are coming here, which you can do when you handle such a case in future. On the third day, she gradually recovered. The hematocrit on the third day was 31%. Just reminding you that normal hematocrit for men is 40 to 50%. This is what we were taught in our undergraduate days. And for women, it is 36 to 48%. A little low. Platelet count came up to 15,000. See how this case progresses. Scary case. It had sunk to 6,000. She was discharged on the fourth day because the platelet count started rising. This is also a message when you can discharge. On 1 week follow-up, she was healthy. Hematocrit was 32%. Platelet count came to 3,54,000. So see, this is how the googly was tackled. You will be scared if you get such a patient in your labor room or in your regular antenatal clinic. Don't be scared. You will have to wait and watch. Keep things ready as it was done. But the obstetrician was surely scared about her labor. Labor outcome, let us see what happened in labor. For me, I will not be worried with the counts which I have seen before. 3,54,000, hematocrit rising. I am not worried, though I am alert. At 39 weeks gestation, she was allowed to go she went in a spontaneous labor, and a healthy female child of 2,630 grams vaginally, Apgar 9 and 10, so not affected child. No abnormality was detected in the newborn. So many messages are coming to you. Next time you have such a googly case, don't panic. Let us see the next googly. And that googly is very quizzical. Like this question mark, it poses many questions. A lady at 26 weeks of gestation presented with 2 days of nausea, vomiting, fever, and abdominal pain. She had no recent travel or sick contact. She surely had history of gonorrhea. She had also undergone a cholecystectomy. However, all her past histories were not contributory at this stage, not giving any clue. So don't get sold out by any of these. Just keep it in mind. On physical examination, her temperature was 38.5. She had right abdominal tenderness with a normal pelvic examination and no signs of preterm labor. Non-stress test, though very early, was reactive at this stage. Hardly any contributory. Right abdominal pain, tenderness. This is what will make the practitioners also scared. Let us see how this case evolved. These are all true to life cases, please, ladies and gentlemen. Nothing out from a fairyland. If it happened to someone, it can happen to you. Therefore, I am bringing them here. Leukocytosis of 15,800 with left shift. That means there will be more neutrophils. Elevated liver enzyme and low platelets. Negative gonorrhea and chlamydia test and urine analysis was not contributing. However, a small finding, wet mount for tricho was positive. Given the severe pain, an MRI of abdomen and pelvis was requested. And preliminary reading was negative for appendicitis. Please note this down. Preliminary reading was negative for appendicitis. Right tenderness, we always start thinking of appendicitis. After observation and treatment with metronidazole and paracetamol, she improved and was discharged home. Diagnosis, not anybody's guess. The next day, till you don't diagnose, the conditions don't leave you, please. हो जाएगा, नहीं होता है. Solve it completely. She returned with fever or up to 39.4 and abdominal pain persisting with rebound tenderness and guarding. The leukocytosis had resolved, but a non-stress test revealed a fetal heart rate of 170. Could be because of maternal tachycardia. I have just uploaded and just given a lecture at Jabalpur and Bhopal societies combined, where a CTG without a maternal tachycardia is not much, the maternal pulse irregularity is not so harmful. If both are combined, then that is not a good sign. So they changed and started broad spectrum antibiotics. The next day, a review of MRI was asked. Once again, it did not identify the appendix, but showed a right ovarian compression and enlargement of the right uterine vessels. She is pregnant, ladies and gentlemen. She is pregnant. Please keep it in mind. See how investigations are not supposed to be your everything. You don't forget your clinical acumen, please. Just keep these things in mind. Given the significant fundal tendency, now making a soup began. Given the significant fundal tenderness, an amniocentesis was performed. All true to life cases. With initial results being inconsistent with infection, no, even on the microscopy, nothing on the investigation. Final cultures also were negative. So now what do we do as obstetricians? Just as they do, we seek a second opinion. They sought a second opinion of a surgeon because of the right tenderness and that so-called rebound tenderness. With worsening right abdominal pain, a surgeon was consulted who recommended exploratory laparotomy. I cannot find anything, now do a laparotomy. The wise man of Bodhayam, in my school I used to be taught this. That was the wise man. Man of wisdom. They all started jumping. They all started jumping. They operated, actually they operated. They did an appendicectomy. Both the general surgeon and OBGYN confirmed normal bilateral adnexa. The pathology findings were also not consistent with appendicitis. So why this was happening? That is a googly. Therefore I brought. Because the investigations were misleading you. What happened? Negative for amniotic fluid culture, blood and urine culture, HIV, antigen antibody both, cytomegalo negative, herpes simplex negative, hepatitis negative, test for influenza negative, mycoplasma negative, Rocky Mountain spotted fever negative. This comes from abroad. The echocardiogram and chest radiograph results were negative. This is what was misleading. But the story continued. The villain continued. Because there is something somewhere where some thorough examination was missing. What was missing? Let us see. At the recommendation of an infectious disease consultant, now so many cooks are joining. And what will happen to the soup, you can imagine. Dr. Anju Madam is a great cook, so she knows too many cooks spoil the broth. My wife and my mother don't allow me to enter the kitchen when they are cooking. At the recommendation of an infectious disease consultant, her antimicrobials were broadened from ampicillin plus gentamicin and metronidazole to piperacillin and tazobactam. चलो ये करके देखो क्या होता है. She received heparin also for a potential septic thrombophlebitis. She remained febrile, continued fever to greater than 40 degrees with persistent fetal tachycardia. Now, God is always kind. And by chance something happened and the googly was handled. Let us see what happened. On hospital day 4, while obtaining a urine specimen, the nurse observed a few small painless ulcers on her labia. You can see it here. Nobody had examined. सब हो गया उसका लेप्रोटोमी हो गया सब. किसी ने लोकल एग्जामिनेशन नहीं किया. Tests from that lesion revealed an HSV2 DNA. That was a human simplex HSV2. Intravenous acyclovir was initiated. She became febrile within 12 hours. Now, HSV2 DNA from her blood confirmed the dissemination, alleged positive. Outpatient acyclovir prophylaxis was continued. She presented in labor at 38 weeks of gestation, was delivered by Caesar. We will not debating that, it is okay. Her neonate was healthy and without evidence of HSV2 infection. So see, this is what happens. This is how a Googly presents. This case comes to us from North Carolina, where one of these team was a surgeon, was an Indian doctor, and he shared it with us. One more Googly situation, and see how once again investigations can mislead you. A 32 years old pregnant woman with a full-term primary breech had cesarean section. She was from Iran and was visiting her relatives in India due to some social emergency. Prior to cesarean, cefazolin was administered as a routine care for the disease, routine of the hospital. A healthy infant was delivered. On the first postoperative day itself, the patient developed a fever ranging from 38 to 39.5. Treated with clindamycin and gentamicin. Fever continued. On the complete examination of the origin of fever, could not be diagnosed. She showed no response to the above mentioned treatment. She was also examined for brucellosis and as she was coming from an endemic area, but all serology tests were negative. Now see what happens. 3 days post-operative, fever continued. Cesarean wound remained unhealed. You can write your diagnosis. What are the possibilities? Please write and see what happens. Prolonged serous discharge without pus was seen in the unhealed cesarean section wound. So the wound adhesions was obvious. The fascia and the skin were open and were left open. There was no septic foul-smelling discharge. No discharge, but the wound had disrupted. Due to opening of the fascia and continuing fever, the uterus was suspected to be the source of infection. We always, as obstetricians, I have seen, we are the most humble people. We are always ready to take a beating. We are never, I have hardly seen, I was one of the exceptions in our hospital, where as an obstetrician being very clear in my fundamental, whatever I knew, I didn't know everything, but whatever I knew, I was very confident of. And I would argue with my surgeon friends, I would argue with my physician friends, not acrimoniously, not in a way where to fight, but on issues. And afterwards, go and have a cup of coffee with them. We were great friends. Some of them were my classmates. Therefore, I enjoyed debating. They would argue with me. But here, obstetricians, very humble and always having a sort of an inferior sort of. Therefore, Dr. Anju's sessions and sessions like that of Pardeshi and all are of great help. They generate confidence in you. And that is what a teacher's job is. Be confident. But what was done? Therefore, they thought it was obstetrics. They did a hysterectomy. Facial stitches were now closed. She had enough number of children, but there was no argument. Recovery was satisfactory for the initial ongoing days. Discharge, obstetrician accepted that there was some problem, amnionitis or whatever which lingered, and therefore good decision. But that is not how the problem leaves you, because you have not solved the problem. The problem continued to jump and make the obstetrician jump. See what happens. Malady continues. A few days later, she returned to the same hospital with severe arthralgia now this should give you a lead, fever, chilling and sweats. The patient was hospitalized for etiological investigations. Friends, go back to your investigations. I already told investigations can be misleading, lest this case would not have come here. Abdominal ultrasound, abdominal pelvic computed tomography, complete blood count, erythrocyte, ESR were all in normal range. But CRP was high. We all know that then we have become masters of CRP since the time of Corona. I, as a teacher, need not remind you, our liver releases more CRP into your bloodstream if you have inflammation somewhere in the body. High levels of CRP may mean you have a serious condition. That means something was wrong inside. The mathematics, the sum was not adding up. You can go back to your diagnosis which you have put on your paper and revisit. Because she was coming from endemic area, the obstetrician and the physician treating became now very insistent. They repeated tests for brucellosis because that fever and arthralgia was there. Therefore, they said she's coming from endemic area. So please read or attend such sessions. There a quick revision takes place. Let the teacher read and bring ready-made material to you. Now, serological test for brucellosis was repeated and the mystery got solved. All tests tested positive now. That time it was too early and you start jumping. Coombs right was positive. Serum standard test was positive. Even 2-ME for completing the list. Those of you might be in medical college. You all know 2-ME test is superior to the standard tube test. The tube test was also done in determining the adequacy of your antibiotic therapy. And 2 negative ME tests is a strong evidence that this is not brucellosis. This is not chronic brucellosis. But a positive means this is brucellosis and your treatment can now be monitored. We all know that brucellosis spreads through direct contact with infected animals by eating or drinking contaminated animal products or by inhaling airborne agents. The biggest source are the cattle. And this is an endemic area and that is what clinched it. As soon as this came, treatment was successfully started. I am completing the list for you for your information. Rifampicin 300 milligram twice a day, doxycycline and streptomycin. And she improved, fever completely stopped. Finally, the wound healed and she went home. This is a slightly googly where confidence of a consultant here. 28 years old, second gravida. Previous Caesar operated for CPD with previous CS in emergency. Mother was on routine antibiotics. 2 spikes of fever, 100 degrees on the 3rd and 4th day. Investigation for fever were normal. Then after there was no fever. Discharge on 7th post-operative day. Returned to the hospital after 3 days with high-grade fever and altered sensorium. Pulse 160. LSCS wound gate because of infection. Now put on piperacillin and tazobactam with metronidazole. Investigations were sent. Except for total count, it was 23,000. All were normal. Culture showed no organism. She had altered sensorium. So CSF was done, but it was normal. So this is one more, just as in the previous cases, I had given you clues. This is a clue. USG abdomen and X-ray chest were normal. Differentials kept in mind bacterial meningitis, viral encephalitis, and tuberculous meningitis. Since the patient did improve, meropenem and vancomycin were now started. A neurophysician's opinion was sought. He is confidently saying, don't be in a dilemma. Whatever be the investigations, whatever be the CF, this is septic encephalopathy. He increased the dose of meropenem. As he advised, it was given. Aggressive treatment of the wound was also started with local dressing. Patient surely showed improvement over the next 3 or 4 days and wound was resutured. I was discharged after 25 days of admission. An old friend has come to visit you. Once again, be very sharp on clinical examination, please. 20-year primary gravida, non-booked case, presented to labor room of medical college with full-term pregnancy and meconium stent lichen. Emergency Caesar was done. And as soon as we do emergency Caesar, we always start thinking of Caesar being the cause, right up to doing hysterectomies. Then after it happened in the second case. Mother and the baby were stable post-operative. Patient discharged on the 5th day. Returned after 10th day. Post-surgery with discharge from the wound and fever. She was readmitted. Temperature 100 to 101. Sorry, here I'm quoting Fahrenheit. You can convert into centigrade. This must be coming out 37, 38. The wound had disrupted and there was a serious discharge. Rectus sheath was intact. There was abdominal distension but no signs of fluid. So they thought, is this septic peritonitis? If you are doing that exercise, you might have written there. Abdomen was doughy. There was no tenderness. She was passing urine and stool normal. See the investigations. Mildly elevated TC but DC normal. MP negative. Vidal negative. Dengue negative. LFT within normal limits. Wait, jara dheeraj rakhiye. Urine microscopy not contributory. Wound swab, no growth. Urine, no growth. Blood culture, no growth. Sputum may have been negative, but continued to have fever. Please don't forget, there was a clue on clinical examination. They got an X-ray done. X-ray abdomen standing, normal. X-ray chest, normal. USG abdomen, normal. Now, they were thinking whether to explore or not. They consulted a senior consultant. And the senior consultant said, examined properly, and said there is a no consistency. They put them, this time you can say empirically, on AKT. Over 15 days she responded. Fever subsided. Wound was resutured. And the patient was discharged after 25 days. That was a googly of our old friend. Just a few days before, I'm coming to the last situation about to end. A patient walked in, but in severe agony. And she complained of pain abdomen. She was just 28, 30 weeks. She was in severe agony. And there was so much anxiety on her face. She said, sir, please do something. I have severe pain. There was no reason for her to go in labor at that stage. I said, do you get an ultrasound done? It is okay. But this is accidental hemorrhage. A typical woody consistency of the uterus. Woody. The doughy consistency of the abdomen. The woody consistency of uterus gave the diagnosis. And they said, sir, ultrasound is not very contributory. Understandable. I said, don't worry, treat her as accidental hemorrhage. Abruption is this abruption. They treated it as abruption. She came on follow-up just 2 days before, and she is fine. So, clinched the diagnosis, and the lead showed that just 24 hours, sudden shooting up of blood pressure. Last situation. This googly is where a physician is doing a self-treatment. See this. This also was in my hospital. Mrs. DVB at 29 years, primary, conceived after ART with twins, was posted for elective Caesar at 39 weeks pregnancy. Wife of a doctor, the extremely bad combinations we all know. So Pardesi also knows, Anju Madam in seniority also knows. Honestly, I'm telling you, I should not use, I'm very wary of wives of doctors. Doctors themselves are excellent patients. Being from medical college, I get many doctors as patients. But wives of doctors, in Gujarati they say, cha karta pyala garam. Always, the cup is more warm than the tea itself. Wife of a doctor, she worked as a homeopathy graduate who had worked with some hospital ICU. खत्म हो गया. एक तो करेला ऊपर से नीम चढ़ा हो गया. LSCS was uneventful. She delivered DADC twins, full term appropriate for day. She was intraoperatively not catheterized. We don't catheterize normally. On postoperative day 4, she had pulse of 113. Never ignore a pulse. Never ignore a round of your hospital. Never ignore it. No fever. Abdomen soft and supple. RS was clear. Tachycardia registered for the first time. Lochia was healthy. I don't mind smelling the pad. I don't mind. Wound dressing was not soap. Her TC was 18,600. Because there was tachycardia, we got all this time. P80 means there is some infection. Urine gave the clue. 25 to 30. This is not a main part of the picture. She was on cefotaxime and metronidazole, to which injection amikacin was with adequate dose was added as per our hospital routine. On 5th postoperative day, she registered a fever of 100.2. Tachycardia 130. It had gone down in between. On insistence of her doctor husband and the physician at whom she worked in ICU, investigations were repeated. We repeated. We have no problems. No ego problem. Total count 17,400. Differential count P76. So, okay. Not anemic. CRP was high. Urine showed 10 to 12 WBCs. So, urine was sent for culture. As advised by physician, now IV levofloxacin was started. Her tachycardia settled. She became afebrile, took a discharge on request. On 8th postoperative day, she came for dressing. It was a subcuticular slit, did not require to be removed. Just a check dressing was done. Wound was clean and had healed well. But she reportedly had recurrent fever, ranging from 100 to 101, usually in the evenings. No engorgement of breasts. Lactation was normal. Uterus has started involving, though post-cesarean it takes time, and this was twins, so it might take time. But here it was like a very well-behaved boy, it has started evolving. Now see, when too many cooks gather, what do they do to the soup? On insistence of her husband and the ICU physician, USG abdomen and pelvis was done. I knew what is going to be the report. Kidney was bulky, typical pregnancy changes are reversing, normally involuting uterus, all other findings normal. Now what is to be done? As there was persistent fever, physician now started meropenem. She was not admitted and insisted on home treatment. Fever still continuing. On her own, she bullied her husband to change ongoing antibiotics. MBBS doctor, antibiotics except meropenem and added tazobactam. Fever remained. What is happening? In the meantime, we got a culture report, and if you may not have the time, but see, so many it was sensitive to. Only these three, ampicillin, piperacillin, and ticaracillin, it was resistant. Then it was sensitive to nearly everything. And this erythromycin and all. Now see what happens. Nearly 24 to 48 hours, she used to change antibiotics as per this report. Now she had a report in her hand. Every 24 to 48 hours, madam, I'll finish in 2-3 minutes. She continued as per culture sensitivity report. Every 24-48 hours. Now she was under the care of that physician, her husband, and her own self. Friends, I had the courage, me and my wife had the courage. This is not OBGYN. We don't require to step in. You may take, we are with you. You may take our opinion if required, but this is not our case. That was the time when our very wise physician, who was my teacher, unluckily he just passed away last year, a great physician, a big loss to our OBGYN or to our medical world in India, in Baroda, Dr. Girish Vaishnav, a great man. He was like a monk beyond the world. And his opinion was taken. First thing sir said was the physician took an opinion. Very senior and sensible physician opinion was taken. He immediately ruled out obstetric cause. He rang me up. He was so nice, humble. Pankaj Bhai, typical Nagars, they are very, he was my teacher, still calls me Bhai. He said, Pankaj Bhai, this is not obstetrics. And left the phone. Don't worry, you relax. And told them to stop antibiotics. Stop antibiotics. Only oral antipyretics as and when needed. Within less than 24 hours of stopping antibiotics, she became ephemeral, her tachycardia settled, and she was completely cured. We know this, we have read about this side effect of misuse of antibiotics, and first time I saw a case where this thing happened. So friends, to finish, to complete, Googlies are like this. They turn, they fall on the leg side and throw up the bells of the on side. See here, it is going on the on side, and the bells of off side are flicked off like this. It can happen to anyone, but that is where a teacher is required. A good coach is required. Such sessions are required. Therefore, I salute people like Dr. Anju. These are actual coaches in modern time. They teach, they make you confident, and then you play shots at Googlies like this and strike a century. Thank you very much, ladies and gentlemen, for your patient hearing. Thank you so much.